everybody. Arlene McGuane here, assistant professor at Russell Sage College in Troy, New York. I am also a doctoral student at Teachers College, Columbia University. I've been a nurse for 25 years. And my area of expertise is critical care, PACU, and ambulatory surgery. Today we're going to be teaching the class about how to do a pulmonary assessment and things to look for and assess. Yuli has agreed to be the patient today, one of our students. So thank you for doing that. Okay, and we're going to start off by first looking and inspecting, because that's where we're going to start our assessment. So as I'm looking and inspecting her chest, can anybody tell me what kind of things am I looking for? Yeah, go ahead.
You're looking for configuration of the thorax, aspect relation, movements, respiratory frequency.
Good. Now, what if she was short of breath, or what kind of things might you see if she was having distress? Yeah.
Retractions.
Good. Retractions. I might see her tripoding.
Increase of movements, increase in respiratory rates.
Good, okay. So as I'm looking at her now, I can see that there really isn't any kind of configuration issue that I can see, no barrel chesting. What would barrel chesting tell me? What kind of disease process might I be thinking about?
Air treatment like asthma, emphysema.
Good,
chronic
perfect.
bronchitis.
Great, okay. So, and I look to see, and I know that Yuli has a little bit of scoliosis, but nothing significant for it to create any kind of respiratory issues, okay? So next we're going to do our palpation. So actually I'm going to have you turn so we can face the class so they can see. Okay, so the first thing that I'm going to do, next step is palpation, and we're just going to palpate. So what are some of the things that I'm palpating for?
The landmark structure.
Good. Good. We might be looking for crepitus. Good. Okay. And what does crepitus tell me?
Air in the subcutaneous space.
Excellent. Okay. So air in the subcutaneous tissue, which I'm not feeling any air in there. And what might cause air in the subcutaneous tissue for a pulmonary?
Air leaking from any pulmonary structure.
Perfect.
Parenchyma, like for example in emphysema or pneumothorax.
Great. Okay, so those are the things that we're going to be looking for. I'm also assessing to see if there's any kind of mass or density or malconfiguration, but I'm not feeling that, okay? And next we're going to go to tactile fremitus. So can anybody tell me, why do we do tactile fremitus?
To check the transmission of vocal vibrations through the wall thorax and,
Perfect.
And translate air or fluid or mass in the middle.
You got it. Okay, so, and we're looking to see if there is, what are we looking for? Asymmetry?
Symmetry.
Perfect. Okay, so I'm going to have you to say the word 99 pretty loudly.
99.
Good.
99. 99. 99.
Good. Okay, so as I'm feeling for those vibrations against the palm of my hand, I'm noticing that they are equal on both sides, which means that we have a normal tactile fremitus, okay? And the next thing we're going to do is our respiratory expansion. So why am I doing respiratory expansion?
We're checking the symmetry of thorax movement as well as the amplitude of those movements.
Perfect. Okay, and so I'm going to have her take a nice big deep breath in. And what I want to do is see that I'm going to kind of push my fingers together, her skin together, and I'm looking to see how my hands move back and forth. Now, as you can see, that was symmetrical expansion, but let's say the right side didn't move as well as the left side. What might I be considering in that case?
Maybe on the right side, atelectasia, pneumonia.
Good. Good. Okay, so atelectasis, pneumonia, and pneumothorax are some of our common ones. So that's great. Good job, guys. Okay, so the next thing we're going to do is we're going to listen. So normally we're going to be listening to, what's the name of our normal breath sounds?
Resonance.
No, oh, well, you're right, I forgot to do percussion. So let me do percussion, but yes, you're right. Our percussion sounds, the normal ones are resonance, okay? So let's do that real quick. Now, what would be something that would be, and can you hear that? What would be something that would create an abnormal sound like a dull sound?
Oh, a mass or fluid.
Good, a mass or fluid, excellent.
Could be pneumonia, hydrothorax, hemothorax.
Great.
Neoplasia.
Okay, so that's what but as you can hear, what did we hear throughout? Resonance throughout. Okay, so we've got normal sounds, okay, percussion sounds throughout. Now we're going to move to our auscultation. Okay, and what's our normal auscultation sound for lungs? Begins with an N, and ends, or V too. Anybody remember?
Vesicular.
Yeah, you got it. Normal vesicular. Good job. Okay, so Yuli's not sick, so we're going to probably be hearing normal vesicular on her. So I'm going to have you take some nice big deep breaths. Just let me know if you get lightheaded or anything while we're doing this. And as you can see, I'm going side by side, so which is what you want to do, just to compare each side. And then from C7 to, C7 to T3 is all upper lobe. Now move into lower lobe. And you want to stay between the vertebrae and the scapula. So I usually just trace my stethoscope around the scapula. It's an easy way to kind of landmark for yourself. Really, your stomach is growling.
It is.
Good. Next, we're going to do the lateral side. So on the right side, how many lobes do I have on my right side? 3. Good. So I'm going to check 3 different locations. Now I'm going to use the seam of her sweater just as my mid-axillary line. Then I've got my anterior and my posterior axillary line. So for the upper lobe, I'm going between the anterior axillary line and the mid-axillary line. And then for the posterior or the lower lobe, I'm going posterior axillary line and then between the mid-axillary line and the posterior axillary line. And now we're going to the 5th intercostal space, mid-clavicular usually, for the middle lobe. Okay? Now we're going to have her turn on the other side. And same thing, mid-axillary line, anterior to mid-axillary line is our upper. And then we've got our posterior axillary line and mid-axillary line, and we're nice and clear. So now we're going to do the anterior, and you want to just do the spots just below the clavicle. And it's important to listen to anterior, posterior, and lateral, because if you only listen to posterior, you're only getting lower lobe. And then you've missed out on the anterior, which is mostly upper lobe. Excellent. Good. Okay, so now we're going to move over to the simulation, and we'll play some adventitious sounds so you guys can identify those. Okay, so now we have our simulation torso, okay? And we're going to play some lung sounds for you guys to be able to identify. So can anybody tell me what this first sound is? Sorry.
Crackles.
Crackles. So what does crackles tell me? Fluid, right? So fluid on the lungs, okay? It means the alveoli can't open all the way. Good, okay? What's this next one? Good, wheezing. It's very loud, so I apologize. And what does wheezing tell me? Constriction of the bronchioles, right? Okay, and usually I hear it on end expiration, whereas with the crackles, I hear it on inspiration, okay? And then let's do this next one. You tell me what this one is. Good, this is rhonchi, okay? And so what's the difference between rhonchi and wheezing? Anybody know?
We think that both can be here at the expiration time, but usually within our listening most at the end of expiration time. Another difference is physiopathological. Within our depending of the decrease of the diameter of small airways,
Good.
and ronchi usually depend of relative diminish of the diameter of the large airways.
Okay. And so I sometimes like, yep, Julie?
You can clear out the rhonchi by coughing as well.
Right, so rhonchi is usually related to mucus, right, okay? Whereas the wheezing itself is more that constriction, right? So with like an asthma attack or all of that. So good job, guys. And so I forgot to mention that at the end of this class, I'm just going to have you do a quick evaluation of my teaching. And it's going to be a 3, 2, 1. So on your pieces of paper that you took out earlier, you're going to write down 3 things that you learned today that you didn't know. You're also going to write down 2 things that you found interesting. And then 1 thing that you still have a question about. And then you'll hand those in to me. I'll review them and we'll address some of the questions that you have in our next class. Thanks a lot, guys.